recorded webinar, which is feedback loop number 1 for the co-design of the Mid-North Coast Safe Space. Thanks, Tina. We'll just begin with some acknowledgements. So firstly, we'd like to acknowledge and pay our respects to the original occupants and traditional custodians of all the lands that we're meeting on today, but particularly the land on which this safe space will be built, and the people, the Biripi people of the Mid-North Coast region, and also to pay our respects to their elders past, present and emerging, and also really to acknowledge the leadership that that Indigenous communities have shown in terms of suicide prevention efforts all throughout this country. Thanks, Tina. And then also to acknowledge people with a lived experience that have been participating, particularly in this LHD in terms of the co-design of the safe space, but also just to acknowledge just the enormously valuable and uniquely valuable expertise that people with a lived experience bring to these social change initiatives and to systems improvement and change for everyone that's impacted by suicide. And also just to really remember the uniquely valuable lives that have been lost, and to remember that that is the purpose for why we've all come together to improve services and supports for people. Thanks, Tina. So just to give you a high-level overview of the process so far in this region, just want to acknowledge that there's been an enormous amount of co-design work and consultation already undertaken, both by the LHD, but also by the LEOs, which are the Lived Experience of Suicide group. That's this fantastic advocacy group that's already formed and has been working very hard in preparation for the Safe Space co-design process that's happening now. So last week what we did was we had the face-to-face lived experience co-design workshop on Thursday in Port Macquarie, and a parallel process was occurring, which was the health professionals were doing some focus group conversations. So Roses in the Ocean was doing that as well. And the purpose now of this feedback loop is, so the webinar and a survey, is to really to feedback the outputs of the co-design workshop and also the focus conversation. So there's a health professional webinar taking place later today, and then to gather much broader views and experiences. So we wanted to get the broadest kind of community input to this process, and that can happen through the survey. So we really encourage people to spread the word and to send this recorded webinar link to people and a link to the survey. Thanks, Tina. So we know that it's very important to get a diverse range of perspectives in the room for co-design to really produce service models that are going to meet the needs and wants of quite diverse people within local communities. And so in the context of a safe space co-design, we know that it's super important to get the perspectives of people with a lived experience of suicide that particularly have had the experience of crisis, and or people that have cared for people in crisis. So that means that in the room, in terms of the lived experience workshop last week, we've had people who have had suicidal thoughts, people who have survived a suicide attempt, people who have cared for someone who has been suicidal and or attempted suicide, and also people bereaved by suicide. Thanks, Tina. We also had a very important 10th co-design participant. His name was Buddy, and he, as we've said here, he kept us all on task and contributed some great ideas throughout the co-design process. So shout out to Buddy. Thanks, Tina. So the process that we took people through last week was that we walked through the emotions and feelings experienced by a person seeking help through ED, and also importantly, the perspectives of people who have chosen not to go to ED or would not go, particularly as a result of previous experiences. And we explored the reasons why they felt that way and what needs were really sitting underneath those feelings at each stage. So what we call the touch points of seeking help through a traditional process of ED in hospital. So they are finding, arrival and initial assessment, waiting, treatment, and leaving. So the following slides that Tina will take you through now really highlight the key points of discussion and feedback from this first phase of the co-design. And everything that was shared in those conversations, we've tried to capture. Beacon Strategies does that. And then we've fed that back, animated by quotes as well. So we can really take you to the place that they were at last week, where people were really sharing some amazing insights, and also some really kind of sharing with us pretty courageously what it was like to go through these processes. And what you'll see is some quite common themes emerging. Thanks, Tina.
Thanks, Carrie. So the reason we did this is we really want to understand the experience that people have when they're accessing the emergency department, when they're thinking about ending their life. And we started by looking at how people were feeling at the time that they were trying to find help, or try to find out what help was available, how to access help. And on the left here, we've got some of the feelings that came up for people. So some of the really strong feelings that were expressed, that a lot of people expressed, were that people felt scared. There was a strong feeling of loneliness, of panic, and some other feelings that came up as well. Feelings of fear, of being alone, of feeling lost. People didn't know what was happening, were uncertain. Some people felt unworthy, and some felt a sense of loss or a sense of hopelessness. So we asked the Leos, why were you feeling this way? And they really helped us understand these feelings. And some of the things that were said were, I've been conditioned to feel unworthy. Another person said that it was about fear of the unknown, of what was going to happen. One person really opened up and explained, I'm from a small town. As a hairdresser, people come to you for a yarn. I didn't want to burden them. They had their own problems. And another person explained, I didn't feel I had it as bad as everyone else. So we took these feelings and we asked people to try and identify the needs that were perhaps not being met, that were the reason they were having these feelings and emotions. And some really important needs were identified at that time of when people are trying to find what help is available and find out how to access things like the emergency department. So some of those needs were a good resource that describes the process of what is going to happen. Also knowing what support is out there in the community. People said that it'd be good if GPs were able to better support people in the first place to talk about suicide. There was also a lot of conversation about the need for collaboration between providers and for transparency from health professionals. People talked about the need for someone to talk to that understands and just gets you, having the ability to speak freely, and the need for somewhere where your feelings are going to be validated. Also, people spoke about the need just to have somebody there to connect to and to feel less isolated. And a lot of people were saying that if they present again, they have that need to avoid waiting in emergency departments, and they'd like to be able to go straight to support. So then we had a conversation about how people felt at the time of their arrival and their initial assessment at the emergency department. And one of the really strong feelings that came up for people there was a feeling of shame. But also people said they felt it was humiliating. Some people felt numb, felt fear. Some people felt quite apprehensive or angry, on edge, embarrassed, or uncomfortable. And we asked the Leos, why were you feeling this way? And they said a lot to help us understand these feelings, but some of the comments that were made, the first time I went to the hospital, mental health department, I was turned away and sent to emergency, and I felt embarrassed, so I left. Another person talked about anxiety being exacerbated because of how you're going to be treated. Someone else spoke about the fear of being judged and being less than them. And another person said, I knew what I'm getting myself in for, a 3-week involuntary admission. So again, we asked the Leos, what are the needs that might be lying beneath these feelings? What needs might not be being met that are leading to these emotions? And they identified again some really important needs. So being treated in a more humane way, the need for an experience that is enjoyable and stimulating. Another person spoke about how they need to know that they're going to get leave when they're actually in hospital. Some people said they need someone to offer empathy and unconditional positive regard. There was conversation about the need to champion the person and let them know they're strong. These are the things that people really felt we need to hear at that time. There's a need for connections through lived experience and the need for workers who have a good understanding of how people are feeling. Also, the need to be treated as an individual, not as your diagnosis or not based on previous experiences of the health professional. So we then moved on to have some conversation about how people felt while they were waiting. And some of the feelings that came up for people at that time, they said while they were waiting, they felt anxious, there was frustration, they felt judged, there was no stimulation and people felt bored and people felt quite nervous. And again, we asked the Leos, why were you feeling this way? And some of the comments that were made then, a comment about the people who were the workers. And they said, what are they getting paid for? They are just sitting around and doing nothing. Another comment was about a nurse. They said, the nurse can't smile and seems cranky and it makes me feel like a burden. Someone said 5 minutes feels longer and it feels like a lifetime. And also there were comments about there being no communication about what is going to happen. So when we asked the Leos what needs might be unmet while they're waiting that are leading to them to feel that way, they spoke about the need for tactile and visual stimulation to keep them occupied during that time when they're waiting. Also the need to not have to wait when they're in crisis. People spoke about taking a person-centered approach. They want to be seen and encouraged and reassurance that help is coming. People spoke about how they have a need for simple things like tea and coffee and origami, and a more human approach to people in crisis, somewhere where they can sit and chat with people. So then we moved on to look at how people felt during treatment. And some of the feelings that came up then, people spoke about feeling controlled, interrogated, scared, trapped. Some people felt guilt and shame. Some people felt confusion or felt misunderstood, disempowered, or vulnerable. But there are other people who spoke about feeling really safe during that time of treatment. And we asked the Leos, why were you feeling this way? And they gave us some really important reasons. So some of the comments they made was they had no voice, no choice, and that there's nothing worse than feeling muted. Another person said, often people made decisions and it was about me without my involvement. Another person said that they felt treated more like a criminal rather than a patient and said, it felt like I was in jail. Nurses and doctors feel like security guards. But there was another person who said that they really felt I'm with people who will keep me safe. So again, we asked the Leos, what needs might be lying beneath these feelings and emotions at the time that you're receiving treatment? And some of the needs they identified were there's a need for active involvement, for choice and control in your care. They feel the need to be heard and validated by someone who understands. They need empathetic service responses in all interactions with staff and a focus on the needs of individuals. So focusing on why rather than what. They also spoke about the need to not have to tell their story to different people every few hours and to build rapport over time with staff. Also the need to feel physically safe during the time of treatment. So then we moved on to look at that time when people are leaving after their treatment had finished and asked people, what were your feelings at that time of leaving? And again, we saw a real mix in feelings. So some people felt quite hopeful and felt joy, felt relief, and they were thankful at the time they were leaving. Other people felt abandoned and directionless and confused. So we asked them again, what were the reasons for these feelings? What was behind these feelings? So some people spoke about how you get your freedom back when you leave and about looking forward to a brighter future when they left. Other people spoke about really feeling like they'd lost support. So one person said, I was only allowed out if I flew to another city and to be looked after by someone who wasn't qualified to support me. Another person spoke about being dumped and going from something to nothing. And another person spoke about how they felt like they'd gone from 24/7 watch to inadequate support. So again, we asked the Leos, what might your needs be when you're leaving? What might these emotions tell you about your needs? And they identified 4 really strong needs on leaving. So they needed to receive help, and they had received help, but they needed more on discharge. They also spoke about having consistent use of action plans and safety plans when they're leaving, and that there needs to be a middle step, not just discharge from hospital into nothing. They also said there needs to be a follow-up, a phone call or something to find out how someone is going. There were some general comments that were made about these experiences. So someone said that in terms of their feelings, I tried to end my life and I failed. And I was thinking, why did I do this to my family? Another person said, I didn't know what was wrong with me. No one diagnosed me until I tried to end my life. Another person said that GPs and other professionals don't want to talk about suicide. People recoil talking about it due to stigma. Another person commented that I had to reach a crisis to get the help. And another person said, I didn't have anyone to talk to about how I was feeling. So everything that we've looked at so far are comments that the information that the Leos provided us about that experience of accessing the emergency department. But we also asked people who had decided not to access the emergency department or would never consider doing this. We asked them about their feelings and their reasons for this. And some of the reasons they had for not accessing the emergency department, one person said, a person that's been there knows that the help isn't the right help. Another person said, what's the point in being put in involuntary admission when once you're there, no one has the time to talk, nurses are busy and doctors are absent. Another person explained that when I'm going to make an attempt, I didn't want the help. Another person said that they were concerned that they would be referred to as a repeat offender or a frequent flyer if they presented again at the emergency department. And another person just made the comment that nothing has changed. It still felt like a waste of time. So a huge thank you to the Leos for providing us all that information about how they felt when they were accessing the emergency department or choosing not to access it. And I'll hand over to you, Carrie.
Thanks, Tina. So the second part of the day was really about starting to do that blue sky dreaming around co-designing the ideal safe space for your region. And we started off by looking at identifying some of the core values that will underpin every aspect of the safe space in terms of how it operates, how it looks and feels, and the type of support people will receive. Thanks, Tina. And so you can see here, we've put on the left-hand side the Ministry Co-Design Forum, the values and principles that came out of that. So towards the end of last year, the New South Wales Ministry of Health really kicked off the co-design process for the Alternatives to ED initiative by bringing together a range of stakeholders, importantly people with lived experience and also LHD staff and other health professionals. And these are some of the sort of the values and principles that came out of that. So empowerment, risk tolerant, non-judgmental, welcoming, responsive, compassionate, strengths focused, hopeful, holistic, self-determination, human connection, collaboration, integration, respectful, evidence-based, dignity, inclusion, choice, and person-centered. So you can see that really is about a very, it gives you a comprehensive picture of the approach that people want this kind of service, this non-clinical support to take. And then on the right-hand side here, this is what came out of the local co-design session with the LEOs, and you'll see that you can really start to pull the threads together there. There are some really important alignment with the values that have already been determined. So locally, it was about safety, and that included emotional and physical safety, empathy, equality for all, and there was a recognition that that meant staff and guests, that welcoming, a sense of belonging, collaboration and networking. So talking about the need for this to be, that the service is able to warmly connect in with other services, respect for all, confidentiality, compassion and care, dignity, honesty, transparency and accountability, as well as information and education. And so the lived experience participants are going to boil those down to a set of, like, generally it's about 5 to 7 core values that will then really be able to help to inform the safe space once it's implemented in terms of the way it needs to operate. Thanks, Tina. We usually also at this point in the co-design ask lived experience participants to draft a set of principles that will really constitute the rules that govern all aspects of the local safe space, and they tend to sort of be derived from those core values, and the LEOs will actually be doing that work as a parallel process, and then we'll feed that draft set of principles, those statements of principles back into the co-design process. So watch this space for that. Thanks, Tina. And here we got to the really exciting part of the co-design, which is that getting people to sit in that real blue sky thinking space to talk about what does your ideal vision of a safe space look like, and a safe space that's particularly got the local flavour that is really going to meet the needs of and wants of this specific local community. So we've divided this up into a few different domains. So environment, so a non-clinical environment, that was very clear. Nice soft background sounds, privacy screens, environment that makes me feel validated, a calm and safe environment, privacy and confidentiality. So perhaps a separate room for people to have sort of private conversations, an outside area, preferably with a courtyard, nature videos, a jukebox, selection of music, sensory activities, comfortable couches, space and time to reduce distress, a snack machine with healthy options, and free tea and coffee. And then in terms of access, that it's easily recognisable and easy to find, that it's open to all, and while there was acknowledgement that there are often organisational constraints that ideally it would never close, free parking that's not timed for both staff and for guests, that it's well lit with secure parking, it's accessible to public transport, and there was even a suggestion that transport is available, so a bus or a van that says safe space operates, and that it's not just simply a drop-in centre for everyone, but it's particularly its purpose is around supporting people in distress. in suicidal distress. And this was a nice quote that we captured that'll lead to the next slide, which is, I want to leave the safe place with a sense of hope, a sense of that someone has really listened and understood me, and I have a pathway moving forward. Thanks, Tina. And that really leads us to the idea of the experience and the support offered. So the experience, people talked about how important it is to just be welcomed with a smile, how important just that first point of contact and connection is, to be greeted by peer workers with a lived experience of suicide. And we'll look at about the staffing mix in the next slide. Good connections with other services. So as I was talking about before, so that collaboration, that networked approach. Someone said like a Byron Bay day spa. I've never been to one, but I can imagine they're pretty cool. Inviting other service providers to the space to connect and collaborate, as I said before. A dedicated event coordinator to organise activities like barbecues, friendly communication between guests and staff at all times. And perhaps a clipboard or even an iPad to write your info on. There was a real recognition that people are often really burdened with a lot of paperwork, that they don't want the workers to have that they don't. Also, people don't want to have to keep giving lots of information about themselves and to keep telling their stories. There was a real recognition that in itself is a re-traumatizing process. So this was a really important element in a non-clinical space, and that no guest will be forced to do anything against their wishes, but remembering the peer worker has a duty of care. So finding that balance, but always about this idea of self-determination with the guests, and also to ensure the space is right for the conversation. Let the guests decide so that their comfort and their voice can be heard under their terms. And in terms of the type of support offered, it was very clear that it was about support that's appropriate to a non-clinical environment, just a place that you know is always there. And also people talked about the need for very timely responsive support, so receiving immediate support, no waiting. And always to have valid, relevant and up-to-date info and resources available. So people particularly be given information about other supports that they might need. And the ability to discuss options and work with peer workers about potential pathways and tools that might be right for people to sort of self-manage and to support their own recovery outside of the safe space. Also, there was a real emphasis on the need to follow up. As Tina said before, that people can be discharged from ED or hospital treatment and feel like that they're just they've gone from something to nothing, and that there's that need for a middle step. So someone saying, don't lose me in this process. And also that linked to that was the idea that there should be warm handovers that include the guest and the peer worker, and if necessary when a clinician's required, but to any other kinds of support. So that collaborative approach and the need for that continuity, and also safe, confidential and understanding environments with no judgments. And that actually leads us to the next slide around staffing. Thanks, Dina. Yeah. So with staffing, there was a lot of discussion around the best mix of staffing, and it was overwhelming agreement that peer workers with a lived experience of suicide need to be staffing these supports, including a diversity of lived experience. So there was a recognition that it will be really important for people to have peer workers to have a lived experience of crisis and recovery, but also importantly that a diversity of perspectives and insights that can be brought from different lived experiences also will be an important element of that peer workforce, and that peer workers that are skilled in just allowing people to be heard. So there was a lot of that discussion and agreement that peer workers that are skilled, active listeners, that's super important for people, and experienced and knowledgeable peer workers, particularly those that have current knowledge about other supports and services, and also the wisdom to know what's out there that's helpful and maybe less helpful. There was then there's also some further discussion around whether clinicians should be involved in the safe space, and this is a section that, as we've framed it here for further discussion, certainly would encourage people that are going to be participating in the survey to have your voices heard here, to express your feelings about this discussion. So some participants did voice the opinion that it may be necessary to have clinicians involved in the safe space. So then the question really became, how do you incorporate clinicians into a non-clinical service model? So recognising that the New South Wales Ministry of Health's requirements around this service model and the basis on which they're funding it is that it's a non-clinical service, that a safe space does not have a clinical referral pathway in or out of it, and that it should be staffed by what they're calling SP peer workers, so suicide prevention peer workers that are receive specialist training. And so this required those people that had raised the issue of potentially needing clinicians to do some real creative problem solving, and we need to continue to do that. And some of the suggestions were that peer workers are trained to screen guests for suitability, and also that clinicians are on hand, so they're not on the floor in the safe space, but would be available at hand to consult with peer workers if and when that's needed, and the guest and it aligns with the guest's wishes. So that is something that will be continued to be discussed and will be resolved through this process of co-design, and certainly something that will be something that's important for people to continue to voice their views about during the surveys. Thanks, Tina. So that brings us to the end of the sort of the content part of this. We are now able to take some questions if anyone has them that is watching this live. But as I said, I really encourage people to send the link of this, which will be up soon on the Roses website. Send it to people that you know, get people involved. This is your safe space. This is the whole region's safe space. So it's super important that the model reflects the needs and wants of as many community members as possible, because that's how you're going to end up with a safe space that is not only effective but sustainable. So please spread the word about that, and also get people involved in participating in the survey as well. It's a real opportunity to provide their ideas and also to answer some of the questions that have come out of the co-design process so far that we need further input from. So just checking to see if there's any live questions. I think everyone's shy. So, of course, we're happy to take questions. Roses is always happy if anyone has questions that you want to direct to us. But as I said, what I'd really encourage is that people send this recording, this link, to as many people as possible. And then also for anyone watching today and that has participated directly in the co-design process so far, to please follow up with the survey, and also to encourage other community members to do the same. So I think that's, there's a question just coming through from Nick. Thank you for providing the co-design workshop. Do you have any feedback for the LHD management in relation to the LEOs group that has been established? Tina, is there anything you'd like to say about the LEOs group? That
Look, I mean, the reason that the process works so well is that they've all been really open with us and, you know, really brave in sharing some of the experiences that they've shared. And, you know, they've obviously put a lot of time in their own time as well, already thinking a lot about what they'd like their safe space to look like. And yeah, it was great to meet with everyone.
Yeah, thanks, Tina. I think it's a really good example of when you have lived experience advocates already coming together and and forming a group and doing that sort of work. It really serves regions well when there's already been that sort of bonded group, because it means people are ready and able to contribute. They've had some capacity building training about using their voices with confidence and purpose, and we really saw that last week. I mean, we were very impressed with just the way in which people were able to bring not just their experiences, but the insights that they've gained from those experiences, which is super important. We all know in advocacy. So yeah, I couldn't speak highly enough of the Leos. We thought they were amazing, and I know that there are people in that group that are already you know, advocating at state levels, and it's fantastic to see the way in which people build their capacity to use their voices and you know, to inform systems change at every level in Australia. So it's really fantastic. Karen. Hi, Karen. She's just saying hello and thank you for hearing us and putting forward ideas. Yeah, it was, as we were saying, it was absolutely our pleasure and, you know, great privilege to have spent time with you guys, and thank you for everything that you contributed. So I think that just about wraps us up in terms of timing. If there's no other burning questions, oh yes, thanks Leah as well. So we really appreciate people that have taken the time to join us today live, but obviously also for people that are watching this recording, thank you very much, and you know, stay tuned. The next, if you have another slide there, a final slide, Tina.
No.
Okay, so I'll wing this, but it's about, okay, next step. So as I said, the webinar and the survey, then we'll also be reviewing all the co-design outputs provided by the LHD. So as I said at the beginning, that there's been some co-design work done, and so we're just looking at the way in which we can integrate that with the co-design outputs that we've just fed back to you now, and also some of the awesome work that the Leos have done and previously as well. So we're just looking at the way in which we can incorporate all of that and feed and fold that into the next part of the co-design. The health professional session 2, which where they'll be provided with the outputs that you've just seen here, and that is on the 23rd of September, I believe. Then we'll have another feedback loop, which is another webinar survey and another review of the outputs, and then there'll be this combined session of joint stakeholders, so bringing the people with lived experience, experts by experience with the professional experts, so health professionals, to have that final combined session to really start to nut out the concrete details of the model here of the safe space, and then we'll have a final feedback loop with a webinar, some survey questions, and final review of the draft outputs of the co-design process. So thanks everyone again for joining us. We really appreciate it, and we'll see you soon.